Greetings from the World Health Organization. My name is Chandra-Mouli, and together with my colleague Jamila Al-Raiby, I will introduce you to this training course in adolescent sexual and reproductive health for 2021. This is part 1 of our presentation, and in this part we will provide you with an overview of the course. The course is titled Meeting the Needs and Fulfilling the Rights of Adolescents' Sexual and Reproductive Health, and it is conducted jointly by the Geneva Foundation for Medical Education and Research in conjunction with WHO's Eastern Mediterranean Regional Office. Dr. Jamila Al-Raiby from WHO's Eastern Mediterranean Regional Office and I are coordinators of the course, are joint coordinators of the course. I work for WHO's Department of Sexual and Reproductive Health and Research in WHO headquarters. And Dr. Jamila Al-Raiby is the regional advisor for children and adolescent health in WHO GFMER. In this slide, you will see the 5 individuals from the region, from the Eastern Mediterranean region, who have been brought together to function as an advisory group for this course. Dr. Mamdou Wahba, Dr. Nafisa Badri, Dr. Nadia Bezad, Ms. Sheena Hadi, and Dr. Ashraf Badar. Their affiliations and their countries of origin are shown on this slide. Developing the materials for the course has been and continues to be a team effort, including, as you can see from this slide, individuals from WHO headquarters, WHO's Eastern Mediterranean Regional Office, the Geneva Foundation for Medical Education and Research, and external experts. We're proud to say that this includes Anand Said, a young professional from Pakistan who brings an adolescent perspective and to the team, as well as a perspective of someone working in adolescent sexual and reproductive health. The course objectives are listed on this slide. It is to build knowledge and understanding in the following areas: the rationale for the provision of a package of effective health and social interventions to promote adolescent sexual and reproductive health, to prevent health and social problems, and to respond to them if and when they arise with particular relevance to the region. That was 1. 2 is WHO's recommendations for the delivery of these interventions, and then special considerations for the delivery of these interventions in humanitarian settings and in the context of the COVID-19 pandemic. The topics of the 8 modules and the dates are listed on this slide. I won't read them out aloud. They are available on the website, but the modules are conducted on a weekly basis. And as indicated in the previous slide, approaches to address COVID-19 as well as the special needs of children, adolescents, and young people caught up in humanitarian crisis situations is addressed in each module. Each module contains a set of 2, possibly 3 PowerPoint slide sets with accompanying talking points, a video recording of each PowerPoint presentation, a video recording of an expert from the region, and a small selection of background documents. Each module also contains an assignment for participants to undertake after going through the course materials. I'll now go on to the teaching and learning methods. There are 3 slides on this. This slide sets out what is required of you as a course participant. Firstly, to connect with your coaches or mentors at the start of the course, and to reach out to them as you need to during the course. to complete and submit the end of course evaluation, and to participate in the end of course Zoom meeting with the organizers and resource persons. That is in general. And for each module, you're required to watch the presentations or go over the slide sets and read the required documents, required reading, to complete and submit the assignment by the date. And if you need to negotiate that, you can speak to your coach or mentor, and to participate in the Google Groups forum. We anticipate that this will take you between 3 and 4 hours for each module, which you can spread out during the course of a week. This slide, the second of 3 slides on teaching and learning methods, speaks to the Google Groups. As I said in an earlier slide, along with each module, we will set up a discussion in the Google forum so that participants can share with each other and also speak to members of the advisory group or coaches and mentors. There's a line-by-line instruction on how to join the group and how to register and how to use the Google Groups mechanism. If you require any further information, don't hesitate to reach out to members of the Geneva Foundation for Medical Education and Research team. This slide lists what the course organizers have done and will do to support you as the participant. As I said earlier, we worked very hard with advice from an external advisory group, but working as a team to develop the materials. But a good set of materials is only one part of this course. One of the key issues in this course, we believe, is the support that could be provided to you by a coach or a mentor assigned to you. So as we said earlier, a mentor or a coach will be assigned to you at the start of the course. She or he will mark your assignment and provide you with feedback promptly. You can always go back and ask for questions on the marking. You can reach out to your mentor by email whenever you want to. Some mentors might set up a WhatsApp network or even provide a phone number. And as I said earlier, we'll have a e-forum for you to share and to learn. Again, I'm stressing that you can always contact the Secretariat if you have any comments or questions. Finally, all participants who send in completed assignments by the required date for all the 8 modules will receive a certificate of completion. The top 10 participants will receive an additional certificate of commendation. They will also get a set of books for personal and professional development. Our aim is to support you in every way we can to make sure that you complete all 8 modules and successfully undertake the course. That concludes part 1 of the presentation, which was an overview of the course as well as the administrative issues that you need to know as a participant. We would now like to go into the second part of the presentation, which is a global and regional overview of adolescent sexual and reproductive health. And we believe this is important for you to have as you settle down to start the course. I will provide you with a global overview, and my colleague Jamila Al-Raiby will then follow me with a regional overview. And my overview is drawn from 2 papers from a Journal of Adolescent Health supplement that was published in the end of 2019, and it took stock of the progress made in the 25 years since the International Conference on Population and Development. The first paper in this series is titled The State of Adolescent Sexual and Reproductive Health, and its aim is to provide an overview of the levels and trends in a wide range of factors related to adolescent sexual and reproductive health since 1994. The first point is that today's adolescents live in a world which is very different from the one that adolescents lived in 1994 when the International Conference on Population and Development took place in Cairo, Egypt. Today there are very new demographic realities. There are more adolescents in the world than ever before, especially in sub-Saharan Africa. There are more boys and young women overall than girls and young women. This is because primarily of the huge imbalance in the male-female ratio in India and China. Adolescents today are growing up in smaller households, and they're growing up in a context of increased life expectancy. So, individuals all over the world, even in low-income countries, are living much longer today than they did 25 years ago. I'd now like to go on to a burden of illness. The key message here is that for some countries of the world, the health problems that they faced in 1994 are largely unchanged. They continue to face problems of undernutrition, of childhood mortality, of maternal mortality. In other countries, some of these health problems have declined in levels. For instance, there is very little undernutrition, and issues such as maternal mortality have really come down to a substantive extent. On the other hand, there are other issues such as non-communicable diseases, mental health problems, problems related to tobacco use and alcohol use, and injuries. And in some countries, they're dealing with both these issues. So you have, for instance, the problems of deprivation and the problems of plenty almost side by side. The third issue that I'd like to touch on is the social context. Today's adolescents are much more likely to be digitally connected. They are much more likely to be enrolled in school and to complete school, and that includes girls and boys. They're much more likely to be growing up in a context of declining poverty. Of course, this supplement was published before COVID-19 has upended the world, and of course that this particular issue changes. In red, what you see on the slide is issues that have really not changed. Underemployment, unemployment is still a huge problem, and even when young people have work, there's an enormous amount of working poverty even among those who have work. This slide celebrates the progress that has occurred in some areas, in fact in many areas of adolescent sexual and reproductive health over the last 25 years. As you can see in this slide, girls and boys are more likely to initiate sexual activity later than they did in the past. Girls are less likely to be married and to have children before 18, and are more likely to use contraception and to obtain maternal health care. They're less likely to themselves support or to experience female genital mutilation. Boys and girls are less likely to have sex with a partner who they were not married to or living with, and they are more likely to use condoms if they do so. And finally, HIV incidence is declining slowly, and that is heartening, although the decline in deaths is still a concern. There are no clear trends in unsafe abortion, although with medical abortion being available now increasingly, there are suggestions that deaths from unsafe abortion are beginning to decline in many parts of the world. And finally, there is limited evidence on sexually transmitted infections, and what evidence is available suggests that levels of STIs and intimate partner violence are high and growing. And in the context of COVID-19, this has even worsened further. My last slide in relation to paper 1, that is the state of adolescent sexual and reproductive health, is that the changes, the trends that I described in the previous slide are averages at the country level, at the regional level, and at the global level. And even within high-income countries, the realities of adolescence are very different. And so you have haves and have-nots. And that is why one of the big areas of focus of the Sustainable Development Goals is to leave no one behind and to address not just improvements in sexual and reproductive health and in other areas on average, but to particularly address the needs of those who have been left behind and who continue to be left behind. The second paper in the Journal of Adolescent Health Supplement is titled The Political, Research, Programmatic and Social Responses to Adolescent Sexual and Reproductive Health and Rights in the 25 years since the International Conference on Population and Development. This paper set out to answer two questions. How have epidemiologic trends and responses to ASRHR evolved in 25 years since the ICPD in relation to the 6 areas listed on this slide? And secondly, what contribution did the ICPD make to this? I'm not going to go over the principal findings of this paper. I'm just going to go to the conclusions, the 5 broad conclusions that we reached. The first point is that some aspects of ASRHR are higher on the agenda than ever before. And this is because of advocacy by a growing body of stakeholders, including young people themselves, high-profile international consultative processes, and international conferences. All these 3 points that I've mentioned drew attention to the rationale for investing in adolescent health in general and in ASRHR. The second point is that there's steadily increasing financial investment in ASRHR, although much of this is from external sources and remains both inadequate and fragmented. There is some investment from countries, but it's largely, as we've identified here, funding from outside. Funding is there now for a growing number of areas, preventing and responding to HIV, preventing child marriage, and increasing access to and uptake of contraception. But there are many other areas for which funding is not available. Our third point is that while there is still many gaps to be filled, there is today a growing body of data and evidence on ASRHR. This is fed into norms and standards to guide policies and programs. On this slide, you will see listed the issues on which we have evidence and the issues in which there are gaps in our perception. What I'd like to touch on is that norms and standards have been developed on a number of issues, but there are gaps, and sometimes these norms and standards produced by different organizations do not say the same thing, which causes confusion. And thirdly, in many places, the guidelines do not reach decision makers. Decision makers, particularly at the subnational level in countries where increasingly programmatic decisions and budgetary decisions are being made. The fourth point is that although implementation of ASRHR policies and programs is weak in many countries, a small but growing number of countries have created and implemented enabling legal and policy environments and put in place strong government-led programs. In this slide, you see child marriage as an example. An area in which laws and policies have been passed, have been communicated, and activities are underway. In other areas, provision of CSC, safe abortion care, and contraception legal and policy challenges remain. Continuing with the same point, NGOs were the first to respond to ASRHR. They continue to play the role of service providers, of innovators, of advocates, as watchdogs, and they have been central to the ASRHR agenda. Over the years, national governments have developed policies and strategies and developed programs, and today in most countries, governments are involved to a greater or lesser extent. But in many places, both NGOs and governments employ ineffective interventions, deliver effective interventions poorly and in a piecemeal manner. But this is changing. This is beginning to change in a small way. My last point is that although there's growing support for addressing some areas of ASRHR, there's ambivalence about other aspects, and there's increasingly and well-financed and well-organized resistance in other areas. So there's support for preventing child marriage, for ending violence against girls and women, but there's resistance to promoting safe abortion, providing contraceptive information and services to unmarried adolescents. And in many places, increasingly, the resistance is better organized, better funded. And this is a big change. On the positive side, there's resistance, people standing up to this resistance, and young people are playing an important role in this.
Hello, my name is Al-Raiby, and I am the Regional Advisor for Child and Adolescent Health at WHO Eastern Mediterranean region. A warm welcome for the training course on Adolescent Sexual and Reproductive Health 2021 for the region. Why this training is important for the region? WHO prioritizes building the capacities at member states to plan, implement, monitor, and evaluate essential health services. Adolescent health, including sexual and reproductive health, is a priority for the region and the member states. Together, we will go through some facts and information from the region regarding adolescents. First one is the adolescents population, which accounts for 19% of the total population in the region, which accounts for 139 adolescents in the region. Around 100 million adolescents are the inhabitants of 5 countries: Pakistan, Egypt, Iran, Sudan, and Afghanistan. And this shows us that there is a huge population for adolescents, and they have needs, and we have to respond to these needs. The region is facing escalating emergencies due to conflict and resulting in more number of population in need for humanitarian assistance. Around 50% of this population in need for humanitarian assistance are below 18 years old. The other information is about adolescent mortality rate, and the Eastern Mediterranean region is the second highest globally, with adolescent mortality rate 115 in the low middle income countries. The main causes for mortality among adolescents from 15 to 19, males and females, are preventable causes. If we see among the males, the first cause is collective violence and legal intervention due to the conflict in the region. Second one is road traffic injuries, interpersonal violence, drowning, and self-harms. The top 5 main causes for death among adolescent females from 15 to 19 are collective violence and legal intervention, and this is due to conflict also. The second cause is maternal causes, and this reflects how much is the need for adolescent reproductive health services, because the child marriage, teenager pregnancies, and other needs. Also, the third cause is the road traffic injuries, tuberculosis, and self-harm. Adolescent fertility rate also in the region is high, and we consider the third highest globally. If you can see, we have 4 countries where the adolescent fertility rate per 1,000 girls aged 15 to 19 is above 60%. And they are Sudan, Afghanistan, Somalia, and Yemen. The other fact is about child marriage in the Eastern Mediterranean region, and where also the region has high rates of child marriage. Child marriage in the Arab region accounts for 40 million brides in this region, and countries like Sudan, Yemen, Somalia, Iraq have the highest number of women aged 20 to 24 who are married or in a union before the age of 15. So what are the national policies available for adolescent health? WHO conducted Sexual, Reproductive, Maternal, Newborn, Child and Adolescent Health Policy Survey in 2019. And in the Eastern Mediterranean region has the lowest availability of national standard for delivery of health services. On the other side, 63% of the countries in the region has a national adolescent health program. Some of these programs have only one focal point. Some of them, they don't have the budget to implement their activities. But this is a good opportunity we can build on at a country level to build the capacities and mobilize resources for those programs to implement essential health services for adolescents. To deliver adolescent health intervention, including sexual and reproductive health, the region has opportunities and platforms, such as the Accelerated Action for Health of Adolescents, which meant to operationalize the adolescent health component of the global strategy for women, children, and adolescent health. And this global guidance has been endorsed in the region in 2018 and urging member states to update, develop adolescent health national policies and plans based on the global guidance. The other opportunity is the regional implementation framework for newborn, child, and adolescent health. And also this has been endorsed by the Ministers of Health, and it is a translation for the WHO General Program of Work and the Regional Vision 2023. It urged member states to develop multi-sectoral plans for adolescent health and to focus an emphasis on the integrated approach. The other one is the Regional Operational Guide for Child and Adolescent Health in Humanitarian Setting, and it provides a programmatic guidance on how to integrate child and adolescent health in a humanitarian setting in the general response to emergency. It is a step-by-step guide to help the program managers to coordinate, assess and prioritize, respond, monitor, evaluate and review the intervention for children and adolescents in humanitarian setting. At the end, I would like to thank you all for your participation in this course and thank you in advance for your commitment. Also, I would like to thank our colleagues in headquarters, Dr. Chandra-Mouli and Marina Pleasance, for their support, and also to the regional team, Dr. Khalid Siddiq, Dr. Bismeen Jadoun, and Anan Saeed, for the great support for the development of the content of the training course. And also to extend our thanks to Geneva Foundation, Dr. Ragibat Idris and Fiona Bond for their organizing this course for the region. Also a big thank for the advisory group, the regional advisory group, for the great support they provided. Thank you.